Get started. All right. Good morning, everybody. Today I'll be talking about this kind of fun topic, rare, but I'll try to explain it the best of my abilities, which is the genetic disorders of the pancreas, mainly, pancreatitis or genetically associated pancreatitis. So, um, I'm going to start by talking about some definitions just to outline some of the things that we should know, and then talk about epidemiology, and then dwell a little bit into the genetics and physiology of, trypsin and genetic pancreatitis, talk a little about clinical presentation, and finally, diagnosis management and the prognosis of those patients. So let's start by definitions. So first definition is acute pancreatitis. This is what we all know. So acute pancreatitis is a syndrome of an acute sudden pancreatic inflammation, regardless of the etiology, whether it's a stone, alcohol, or genetic. Still, you can have an episode of acute pancreatitis. An acute recurrent pancreatitis, so 1/3 of those patients who actually end up having acute pancreatitis may develop acute recurrent pancreatitis, which means they have an acute recurrent episode, and 1/3 of those who have an acute recurrent episode end up actually developing chronic pancreatitis. The etiology of recurrent pancreatitis can be complex and multifactorial. It's not necessarily just one specific cause. The other term is hereditary pancreatitis, and this just means if you have acute recurrent or chronic pancreatitis occurring in an autosomal dominant fashion. So there's an autosomal dominant pattern of inheritance in a family pedigree, and it also can describe an autosomal recessive pattern of inheritance with high penetrance, which means if you have the gene, you probably will have the disease. And then finally, familial pancreatitis, which, in layman term, familial, unlike hereditary, hereditary means that you will inherit it from your parents, but familial just means runs in families, right? It's just acute pancreatitis that occurs in a family with an incidence that is greater than that expected by chance alone. Somebody keeps logging in and out. It's a little, it's fine. So the familial pancreatitis can, it may or may not be attributed to a specific genetic defect, but we'll talk about one that at least is. So how about the epidemiology of pancreatitis? So remember, hereditary pancreatitis. Hereditary pancreatitis is a really very rare disorder, and you probably will not encounter it. And you should only consider it after you exclude all other causes of recurrent pancreatitis. The prevalence really varies greatly between different cities, different regions, different countries, and different ancestral groups. The true incidence is not really well known. We didn't deep sequence all the genes, the important genes for all the population, so we're not sure what is the true incidence of hereditary pancreatitis. And in terms of when do people with hereditary pancreatitis actually develop their first episode, there was a single center study that found 19% a genetic etiology of the first episode of acute pancreatitis in children, which means if children have acute pancreatitis, potentially 19% of them might have hereditary pancreatitis or a genetic defect that's causing driving the pancreatitis. What's really important for our population, our purposes here, Kings County, SUNY Downstate, and the populations that we serve of African ancestry, there's really no reports of hereditary pancreatitis families or any individual that has been published of African ancestry, at least as of 2016. However, there was a Spinc-1 variant. We'll talk more about Spinc-1 that was observed in some African patients, but with pancreatitis. But there isn't like any functional analysis that contributes this to actually being the cause of the pancreatitis, and it could be just a common polymorphism that they found. And the early estimates, at least from a paper from 2014, of the prevalence of hereditary pancreatitis in the United States, it's about 1,000 cases. So again, it's an extremely rare condition, and unlikely that we will see one. But it is important for us to understand how it comes about. And so I will talk briefly about the genetics and the physiology of pancreatitis in general, but specifically hereditary pancreatitis, what can drive this. So let's review the story of trypsin, okay? So if we go back in time, the history of trypsin, what trypsin means, the meaning of the word, it means to rub in, and the reason it's called that because initially they would bring the pancreas and they rub it with glycerin, and that's how they would obtain trypsin, and so they call it trypsin. And it was first described by Wilhelm Kuhn in 1862, who also coined the term enzyme. So this is kind of an excerpt of his passage where he describes both enzyme and trypsin in his book. And that was back in 1862. I mean, we came a long way. So trypsin is also called a serine protease. It's called a serine protease because it cleaves the peptides at the serine residue. And so specifically, it's one form of trypsin, which is the cationic trypsin, trypsinogen, is called serine protease 1, and it's encoded by the gene PRSS1. And this is called cationic because it migrates to the cationic electrode in electrophoresis. In contrast, you have anionic trypsinogen, which is PRSS2, and mesotrypsinogen, PRSS3, which are less important, at least for the purposes of our talk here. The main one that we should know is PRSS1, which codes for cationic trypsinogen. And so in terms of physiology, trypsinogen is made in the acinar cells in the pancreas, in the exocrine part of the pancreas, and then excreted into the ducts, and then finally finds its way into the small intestine, into the duodenum. In the duodenum, you have the enterokinase, which acts on trypsinogen to activate it into trypsin. And then in turn, trypsin activates more trypsinogen into trypsin, and then it activates the rest of the, a lot of the enzymes that are secreted by the pancreas and in the brush border that are secreted usually as zymogens, which are inactive forms of enzymes. And then trypsin basically activates all these enzymes. Ones to remember here is chymotrypsinogen and carboxypeptidase A. These are important enzymes that we'll talk about later in this talk. So I adopted some of this talk and some of these really beautiful illustrations by Dr. Di Madaria, who is the president of the Spanish Association of Gastroenterology. And he had a very nice talk about all those. And so I adopted some of his slides. So this, again, shows you that trypsinogen, secreted in the duodenum, and you get the enterokinase activates trypsinogen into the active form of trypsin, and in the process there is this TAP molecule called the trypsinogen activation peptide that gets released. Not very important. What's important for us to know is that trypsin gets activated this way. Also, trypsin, once it's activated, it goes back and it activates more trypsinogen into more trypsin, and goes to activate more pancreatic enzymes. So you can imagine that if you have trypsin becoming inadvertently activated in the acinar cells, it will activate a lot of this trypsinogen available, and you will end up with a problem. So what stops this? What regulates trypsin? What tells trypsin no, stop being activated? There's few proteins. Probably there's a lot, but the ones that are clinically important and important for us are a couple at least. The first one is this Spinc-1, which is this is an intrapancreatic enzyme called serine protease inhibitor, Casal type 1, and the cool acronym Spinc-1. And what it does, it inhibits trypsin by binding to the active site of trypsin. So again, this is secreted by the acinar cells, and it keeps the trypsin level low inside the pancreas. The other enzyme or other protein that also works in regulating trypsin is chymotrypsin C. Again, if you remember, chymotrypsin C comes from trypsinogen, and which is activated actually by trypsin. So you've got an active form of trypsin that activates CTRC, or chymotrypsinogen C, to become chymotrypsin C, and chymotrypsin C in turn deactivates or inhibits trypsin. So it promotes trypsinogen degradation by increasing the vulnerability of trypsinogen to become degraded. And so CTRC activation will result in less trypsinogen available to be active. And so both of these molecules work hand in hand, Spinc-1 and CTRC, to block or maintain the activity of trypsin and trypsinogen low in the pancreas. And so after kind of understanding all that, you can imagine that anything that goes wrong in any of those mechanisms, then you might end up with a problem. You might end up with a reaction and autodigestion and eventually inflammation and pancreatitis that may lead to hereditary or familial type of pancreatitis. So what are the main genetic pathways that may lead to pancreatitis? There are 3 described pathways. They're distinct pathways. And the first one, it's a trypsin-dependent pathway. So the problem lies in trypsin itself or the trypsin pathway that we just described. The second one is a misfolding dependent pathway. If you have some sort of misfolding of proteins inside the acinar cells, then you might end up with accumulation of certain substances that might lead to pancreatitis. And then finally, you have the ductal pathway. If you have any problem in the ductal cells, then you might end up with, again, causing clogging up of the pancreas and causing pancreatitis. And so these first two pathways, they're acinar, or like is within the exocrine part, within the acini, and then extra-acinar or ductal pathway is this number 3. So let's start by looking at the trypsin-dependent pathway. So the first one that you might imagine happening is if you have a PRSS1 mutation. So if you have a mutation in trypsin itself, or trypsinogen itself, then you might end up with a problem. And PRSS1, actually, the first time it was described, a mutation in PRSS1 was in 1996, and it was described as a cause of hereditary pancreatitis by Dr. David Whitcomb, who still is sitting on the chair of the Association of Pancreas and Pancreatology. And so certain mutations of PRSS1 are associated with hereditary pancreatitis. And the important thing for us to know is that these mutations actually are inherited in an autosomal dominant fashion. The reason for that is you don't need both genes to be defected to get pancreatitis. Only one, if you only have some of the trypsinogen gets activated or mutated, then that is enough to induce the phenotype of pancreatitis. Most patients carry this specific mutation, R122C or R122H. I'll show you a slide that describes them. And these specific mutations, actually, they prevent the trypsinogen from being degraded by CTRC. So it creates a CTRC resistant trypsinogen, while an N29I mutation increases the trypsinogen autoactivation. So trypsinogen inherently can become autoactivated, but generally that doesn't happen too much unless you have this mutation, N29I, which drives trypsinogen to become activated. And it's important for us to remember that 80% of hereditary pancreatitis is actually due to PRSS1 mutation. So the vast majority of these genetic associated pancreatitis that you will see, if you see, is going to be PRSS1 mutation. And so this is just to summarize what happens. So you can either have the N29I mutation that increases the autoactivation of trypsinogen into trypsin and ends up in autodigestion and triggering the pathways of pancreatitis. Or you can have a resistant trypsinogen to chymotrypsin deactivation, and that will end up again with increasing availability of trypsinogen to become active and end up with pancreatitis. The other mutations you can have is a Spinc-1 mutation. So remember, Spinc-1 works to deactivate trypsin in its active form. If you have a mutant Spinc-1, then that will predispose the patient to pancreatitis. However, because this is a cofactor and you don't need much of it to inhibit trypsin to prevent pancreatitis, then really the phenotype or the genetics of this is inherited as an autosomal recessive pattern, which means you do need to have both Spinc-1 mutations in order to develop the phenotype of pancreatitis. This was first actually described in 2000 by Dr. Heiko. And some of the important Spinc-1 mutations is this N34S, which presents in 10% in patients with chronic pancreatitis. And 1% in the controls who don't have pancreatitis. Not necessarily to have the double hit, but if you have the double hit, then you're definitely predisposed to develop recurrent pancreatitis and chronic pancreatitis. And then finally, a CTRC mutation, which is the chymotrypsinogen C mutation, or which regulates trypsinogen, or it marks trypsinogen for deactivation and degradation. So if you have a CTRC loss of function mutation, then this will increase the availability of trypsinogen to become trypsin in the acinar cells and again trigger pancreatitis. And this again was more recently even discovered by Dr. Rosendahl in 2007. So let's just kind of zoom out and summarize these pathways I just talked about. Okay, so again, you have the PRSS1 trypsinogen gene, and this can either become auto-activated and becomes trypsin, and this auto-activation can happen due to a mutation in the actual trypsin gene itself. And then you have the CTRC, which tags trypsinogen for deactivation, and if you have a CTRC mutation, then that will cause pancreatitis or will predispose you to pancreatitis. And finally, you have the Spinc-1 gene or the Spinc-1 protein, which inhibits trypsin, and if it's mutated, then you will be more likely to get pancreatitis. The next pathway is called the misfolding pathway. So the misfolding pathway or misfolding dependent pathway, it just means you have some sort of misfolding of some sort of enzymes inside the acinar cells. We know the acinar cells produces a lot of zymogens, produces a lot of enzymes. And most of these enzymes are actually produced in the endoplasmic reticulum, where you have the ribosomes coding the mRNAs and then producing these enzymes stored in the ER. And the function is that if you are normally producing these, then you will be able to secrete them from the endoplasmic reticulum and finally into outside of the cell, into the ducts. And so you can imagine if there's any sort of problem or misfolding of these proteins, then these will accumulate in the endoplasmic reticulum, and this will cause a stressed endoplasmic reticulum and eventually cell damage. And any cell damage to the acinar cells, which is the primary insult in the pathophysiology of acute pancreatitis, can eventually lead to pancreatitis. One of the notable enzymes or notable mutations that can happen is this carboxypeptidase A or A1 mutation. And this mutation can, again, any mutation really can happen, but the reason we talk about this specifically because it's clinically it's clinically relevant, and we see it in people with pancreatitis sometimes. And so when you have this specific mutation, this will result in a misfolded protein, misfolded CPA1, and this will result in impaired secretion, intercellular retention of this enzyme, and ER stress, which eventually leads to pancreatitis. Now, this had been really described as a cofactor in patients with idiopathic or sporadic pancreatitis, but very rarely can be associated with hereditary pancreatitis. And again, you can imagine you don't need both hits to cause this, right? You only need one misfolded protein of the two genes that you produce, and that will be enough to cause ER stress, which means that the genetic inheritance of this will be autosomal dominant to produce the phenotype of pancreatitis. And again, I keep zooming out to remind everybody of the pathway, just for us to remember. Again, you have trypsinogen in a healthy pancreas. Trypsinogen can be inhibited by Spinc-1 and CTRC, but more so trypsin is inhibited by Spinc-1 and CTRC. And if you have either a mutated PRSS1 that causes activation, or you have a mutated Spinc-1 or CTRC, then you might end up with pancreatitis. And then finally, if you have a mutated CPA1, you will end up with accumulation of misfolded CPA1 and ER stress and end with pancreatitis. So this kind of summarizes all the acinar pathways, or the pathways that happen within the pancreatic acinar or exocrine cells. How about the ductal pathways? So ductal pathways are important that may cause pancreatitis, and one of the most famous ones that, if you ask even a medical student, will tell you about it, and this is cystic fibrosis. So the CFTR associated pancreatitis. So this was first described in 1998 as a cause of pancreatitis associated with cystic fibrosis. And it is important to recognize the role of TFTR protein in the pancreatic ducts. So it is important in secreting water and bicarbonate, and this in turn helps flush out all the zymogens, and eventually it will prevent a premature activation of pancreatic enzymes, including trypsinogen, and will flush all these enzymes into the duodenum and neutralize gastric acid there. That's the function of the bicarbon water secreted by CFTR. And so patients who are homozygotes, those who carry two mutations of CFTR, they have cystic fibrosis disease, and they have the lung manifestations of cystic fibrosis, and 85% of them eventually develop pancreatitis and will develop pancreatic exocrine insufficiency during the neonatal period. So it's early onset pancreatitis and exocrine insufficiency. So patients with classic cystic fibrosis, they have a normal pancreatic exocrine function. They may have episodes of acute pancreatitis. So if those 15% who don't end up developing the exocrine insufficiency as neonates, we might see them as adults developing acute recurrent pancreatitis, but eventually will develop chronic pancreatitis. The more important ones are the heterozygotes. So those who have a heterozygous carrier mutation of CFTR, or they are compound heterozygotes. These they don't have the classic cystic fibrosis phenotype. So they may develop pancreatitis without having emphysema, without having lung features, and without having any other organ involvement. So these mutations in CFTR, they're really pretty frequent. You can see them in normal populations. You can see them in populations with low risk of pancreatitis, or those populations that don't even end up developing pancreatitis. And so how do we know the risk of pancreatitis in those? So the idea is that this risk is really dependent on how strongly the mutation is affecting CFTR function and the homozygosity. For example, if you have this F508 mutation, which is the strong mutation, the classic mutation, and you only have one hit of this, then your odds ratio is 2.5 to develop chronic pancreatitis. While, if you have a one strong mutation and a one mild mutation on the other gene, then your risk is a little bit higher, and so on. The other gene that is important for the ductal pathways of hereditary or genetically associated pancreatitis is this calcium sensing receptor, the CASR. So calcium sensing receptor is present on the pancreatic ductal cells, and it detects high levels of calcium in the pancreatic juices, and it in turn increases the secretion of fluid to flush out more of this calcium. And this avoids stone formation and eventually avoids pancreatitis. If you do have a mutation in the CASR gene, and this had been described in patients who have idiopathic pancreatitis and described as a risk factor to develop chronic pancreatitis in patients who are heavy drinkers. So it doesn't per se cause pancreatitis, but it can be a risk factor. And again, if you look at the duct cells, you see on the ductal side, you have the CFTR, which promotes chloride and bicarbonate secretion, and in turn water secretion. And you have the CASR, which senses calcium and in some unknown mechanism promotes more water secretion. And if you have a CASR mutation or a CFTR mutation, this will cause impaired secretions and will end up in pancreatitis, or increasing the chances of developing pancreatitis. So again, just to summarize, you have the acinar pathways, which involve PRSS1, Spinc-1, and CTRC, and then you have the ductal pathway, which involves CFTR and CASR. in genetics, or the genetics of acute pancreatitis or chronic pancreatitis. And again, if you want to really dwell deep into those genes and see who of those people who have these different mutations have a higher risk of developing pancreatitis, you will see that PRSS1 gene is by far the highest prevalence or the highest risk of pancreatitis. So it's an autosomal dominant, and this will lead to a very high risk of pancreatitis. And then, in second place comes Spinc-1 and CTRC, and then finally comes the rest of the ones, the CFTR mutations in the different flavors. And then I think this is a better table to kind of look at it, is that if you have a gene, if you have a PRSS1 mutation, then this will lead to hereditary pancreatitis. And if you have a Spinc-1 double mutation, right, so you need the double hit because it's a autosomal recessive gene, then this is what we call familial pancreatitis. And really, these are the important ones that we should remember. And the rest here are just a compound or compounded mutations, including CFTR, CTRC, and Spinc-1 in their different forms. So now that we kind of understand overall the genetics behind hereditary pancreatitis, let's talk about clinical presentation. How do these people present? And you guessed it, right? The presentation really is similar to those who present with acute recurrent pancreatitis of other etiologies. However, the difference is that patients with hereditary pancreatitis may present in early childhood. So if you take the autosomal dominant, the most common type, the PRSS1 type pancreatitis, this typically presents with recurrent acute pancreatitis in childhood or early adolescence, and then it later develops into a chronic pancreatitis in late adolescence or early adulthood life. And very important for us to remember is that the risk of pancreatic cancer in those patients starts to increase exponentially at the beginning of the 5th decade of life. So at age 50 is where they have the highest risk, start to have very high risk of developing pancreatic cancer. Those clinical features are similar to those seen in chronic pancreatitis, i.e. they will have abdominal pain, they will have maldigestion, malabsorption due to pancreatic exocrine insufficiency, they will have eventually pancreatic endocrine insufficiency, will have diabetes due to islet cell damage, due to all those episodes of pancreatitis. And so if you look at kind of the percent of patients, this is a nice graph from a study from 2018 that looked at about 200 patients of hereditary pancreatitis, and looked at the risk and the percent of patients of who developed what. So the first symptoms, you can see by age 10, 50% of them develop their first symptoms or the first episode of acute pancreatitis. And then, by age 40 or 50, they start to develop malabsorption, diabetes, and then, starting age 40 and then 50 specifically, you will have increasing incidence of pancreatic cancer. Again, which is pretty important here, and it's very important in determining the prognosis of those patients. So how about if we look histologically, if we do end up, for some reason looking at the histology of hereditary pancreatitis. Again, this resembles chronic pancreatitis, except for a few different things or few characteristic findings that are not really very specific findings. So if you look at the gross pancreas for somebody with hereditary pancreatitis, it will look soft and shrunken pancreas, and it will have marked atrophy with actual fatty replacement of the pancreas. I know we heard of fatty liver, but this is fatty pancreas. And it's if you look at it histologically, you again see parenchymal replacement of the normal exocrine tissue of the pancreas into adipose tissue. And in here you might even see some amyloid deposits in a background of what we call lipomatous pancreatic tissue. And then finally you see the islet cells just surrounded by adipose tissue, and you can actually see fibrous bands kind of running through the pancreas. So you will get lipomatous fibrotic pancreatic tissue with amyloid deposits. So let's talk about the pancreatic cancer risk. We kind of brushed upon it a little bit, but We know that the true risk is not really measured because, again, it's lack of big population studies just because of the rarity of this disease, but is estimated kind of to be 7 to 20% in a 20-year-long study. And patients with hereditary pancreatitis should really be urged not to smoke, not to drink alcohol, and to follow whatever lifestyle is available to them. The question for us is, do we screen? And I think we brushed on this in a previous, the pancreatic cancer screening lecture before, but the AGA guidelines, just to remind everybody, was updated in 2020, the pancreatic cancer screening in high-risk individuals. And in general, they're saying for high-risk individuals, we should begin screening at age 50 or 10 years younger than the initial age of the familial onset. But they also talk about specifically for hereditary pancreatitis, is that for people with PRSS1 gene mutation or who are carriers or who have hereditary pancreatitis, we should initiate screening at age 40, not at age 50. So they are high risk, but they have the mutation, and so we start at age 40 in those patients. And how do we screen? We screen with an MRI or an EUS. To see if there is any any findings. Now, there is no real consensus on the surveillance, which means once you get that MRI, then you interpret the results. There's no real consensus on how often do you do it, every 3 years, every 5 years, or what do you do exactly. And this is really by clinician, depending on the clinician and case-by-case basis. The thing that we have to remember is those patients with chronic pancreatitis and hereditary pancreatitis, they will have a very distorted morphology of the pancreas. They will have very distorted ductal morphology. And so when you have the MRI and EUS, you really have to interpret it very carefully, and it can be challenging sometimes to interpret. The other thing I want to kind of talk about briefly, we all heard about IPMN. Every conference we talk about IPMN, every radiology conference. But I don't know if we all heard about PAN-IN. And these are kind of similar things. What is PAN-IN? PAN-IN is a pancreatic intraepithelial neoplasm. So this is a microscopic finding. So it's a microscopic. Again, it can be papillary like IPMN, but it also is usually flat. It's a non-invasive epithelial neoplasm. And this occurs in the pancreatic ductal epithelium. The hallmark is that this is less than 5 millimeter of ductal dilation. This is usually a macroscopic finding that is usually found on biopsies, or when they do surgical resection of the pancreas, they look under the microscope and they describe these lesions. And these lesions can be either low-grade, PAN-1, or it can be moderate dysplasia, or it can be carcinoma in situ, or high-grade dysplasia. And again, histologically, they can start developing these columnar cells in the ducts, and then they start to aggregate, and then finally you can get carcinoma in situ, where you have actual high-grade dysplasia. And just to kind of take a look at this, if you have this is a section of the pancreatic duct, where you have acinar cells here, and then you have a duct right here, and you have nice cuboidal cells that are lining the duct. And then if you have a PAN-1, you start seeing these ductal cells becoming more columnar, and they even form papilla, what looked like papillary formations. And then finally, if you have a PAN-3, which is a carcinoma in situ, you will have a high-grade dysplasia. The importance of knowing this terminology, or knowing this, is that this had been described in association with hereditary pancreatitis, and specifically with patients with PRSS1 related pancreatitis. And in those patients, some of those, in one study, those patients who underwent surgical resection as a treatment of their chronic pancreatitis, when they looked under a microscope, they actually saw these lesions. In the low or average risk population, the discovery of these does not change the course, even if those are discovered incidentally. And in fact, there was one study who looked at a 10-year follow-up of about 584 patients, and they saw no difference in the development of pancreatic cancer, no difference in the population. So these are people who had pancreatic cancer, got resection, and they looked at the remnant pancreas that are healthy, and they saw these lesions, and they didn't see any real association between the presence of these and having a higher grade of pancreatic cancer or risk. Again, the risk is unknown just because they're microscopic lesions, you can't really see those on an MRI or an EUS. So these are histologic findings. There's some studies that look at these and they're saying this could be really the beginning of pancreatic cancer. We may start to have to look at these at some point, but at least not yet. So let's talk about the diagnosis of genetic pancreatitis. So when you are suspecting a genetic cause of pancreatitis, this is going to be based on your clinical history. This is going to be based on genetic testing. So you will suspect this in patients with idiopathic acute pancreatitis, where where you looked everywhere, you did an MRCP, you did everything, and you couldn't really find a cause. Or if you have a recurrent idiopathic acute pancreatitis, or patients with chronic pancreatitis and you don't have a real etiology of why they have it, then maybe you can suspect this. And you should be able to review the pedigree of the family and recognize what an autosomal inheritance pattern looks like. So most labs nowadays are able to test for the most common genes. They're able to test for PRSS1, CFTR, Spinc-1, and CTRC mutations. But if you need to look for these more rare genes that we didn't even talk about today, then there's an extended panel that might be available. The question is there real guidance on whom to test? So, you can suspect it, but who to actually send for a test? So there is guidance, and it is kind of outdated from 2001, and this comes from the Euro-Pancreatic Association, the EuroPac. This is actually their very nice logo, and they look at people who are either symptomatic or asymptomatic. So let's talk about the symptomatic, and these are the people we will see, right? Symptomatic, who have actual pancreatitis. So who to send test? If you are symptomatic and you have any one of the following, then it is reasonable to test. So if you have an unexplained episode of pancreatitis as a child, if you have idiopathic chronic pancreatitis and you're less than 25 years of age, you have family history of recurrent acute pancreatitis, or a family history of idiopathic chronic pancreatitis, or a family history of childhood pancreatitis, or if you have any relatives who are known to carry any mutations, or there are recurrent attacks of acute pancreatitis without an identifiable cause. And then finally, if you're enrolling these patients for studies, for research protocol. But how about asymptomatic patients? Can we test those? So this is called predictive testing, which means you're predicting that this patient might have the genetic mutation. So this is really only considered in individuals with first-degree relatives and there's a known PRSS1 mutation. The bottom line, these patients who are asking you about testing when they're asymptomatic, the best thing for us to do is to refer them for actual genetic counseling. And, remember, if you do send anybody for any genetic testing, regardless, pancreatitis or FAP or what, you really should also refer them for genetic counseling because that will alter kind of the course of their disease. And then finally, let's talk a little about management. Management is similar to those patients with chronic pancreatitis. The important advice for these patients is lifestyle modifications, and you want to encourage them to absolutely abstain from alcohol, absolutely abstain from smoking for life. There are some studies looking at antioxidants and COX inhibition, but these are really not well studied. There's no real guidance about using those to prevent pancreatic cancer or pancreatitis. And then finally, pancreatic surgery. Usually they do this in the form of pancreatectomy with an islet cell transplant, and this is considered in the pediatric population, especially with those with recurrent disease, just due to the quality of life. So in terms of prognosis for those patients, so the mortality rates in patients with hereditary pancreatitis is increased, right? And it's increased specifically in patients who have pancreatic cancer. So really their prognosis depends whether they end up having pancreatic cancer or not. And that's why our therapy should focus mainly on trying to prevent those patients from getting pancreatic cancer and screening them early on if they do have it. And those patients who have hereditary pancreatitis who don't have pancreatic cancer actually have a mortality that is similar to those in the general population. And so just to kind of give you the take-home points, the final conclusion of all this is that, remember, the most important thing for us, PRSS1 mutation is an autosomal dominant one, develops hereditary pancreatitis. Spinc-1 mutation, autosomal recessive, familial pancreatitis. Obviously, there are the other genes. And then when you have a genetically test, you test those who are symptomatic, plus if you have any of the 6 criteria, which means you have clinical suspicion. And remember to refer those patients to genetic counseling. And then finally, remember, if you have a PRSS1 mutation, pancreatic cancer screening starts at age 40 with an MRI and EUS or an EUS. And remember that there is a distorted morphology, and you really need to consider carefully what you're seeing on this imaging. I'd like to thank Dr. Queno for supervising this talk, and thank you everybody for listening. And I'll take any questions you guys have.
Hey, Mohammad.
Yes.
So how frequently should one be screened? For example, if you see a patient in the clinic and they say, like, she's 50 and say, my brother died of cancer at the age of 55, and they want to be screened, you would get genetic testing. How frequently would you screen, and what modality is like preferred?
So if I understand your question, you mean screening?
Yeah, like how frequently would you screen them after you start?
So there is no real guidance how to. Somebody's echoing. So we're not sure how often we screen those, but you will have to get an EUS or an MRI initially at age if they do have the PRSS1 mutation. If they only have a family member with pancreatic cancer, that's a totally different guideline. But in general, if you wanna you can either test them for the PRSS1 gene if they have a first degree relative with the known mutation, or they are symptomatic. They have acute pancreatitis and they have one of these. But if they are, if they're completely asymptomatic, unless some of their first degree family members have a proven PRSS1 mutation, you don't typically send them for testing.
Hi, Mohammed.
Yeah.
Can you hear me?
Yes.
Excellent talk. You really clarified a lot of important points. Difficult topic. Just wanted to make one comment. You mentioned PANIN, the PANIN lesion. I don't know if I heard you correctly. You said they were not consequential if you find them. They're the only known precursor to ductal adenocarcinoma pathway. And, the understanding that I have, and I think which is in clinical practice, is that PANIN-3 is high grade, and there's a very high risk of progression, and it is significant. For example, if they do a pancreatic surgery, surgical resection of IPMN or adenocarcinoma, and the margin shows PANIN-3, then it's almost considered like a positive margin. And, they are it's unknown exact progression. I guess that part is not clear, but they should be in a higher, more intense surveillance. The PANIN-1, yes, it is commonly found even in chronic pancreatitis. So the PANIN-3, I think it's important to note, it's the kind of the high-grade dysplasia equivalent. Just thought I'd point that out. And yeah, I mean, it's more in the ductal pathway, so you can see that in IPMN or adenocarcinoma. Yeah.
Thank you, Dr. Vignesh. I agree with you. From what I was reading about it, is that as you mentioned, it is one of the real known precursors of adenocarcinoma, and it has a different pathway than the IPMN, what I saw is that there wasn't like real guidelines about like, if you find PANIN incidentally, what do you exactly like do with it? But obviously, if you find PANIN-3, as you mentioned, I think, it's important to consider that this has potential of high risk potential of becoming something, just because it has a high grade dysplasia.
Mohammed, hi, it's Dr. Frank. I mean,
Yes.
I agree with Dr. Vignesh about the PANNs because the issue is that we can't really diagnose it in general. You know, like you said, MRIs, EUS is not going to find it. The interesting thing about it is that so because of that, I don't think there's any guidelines, you know, as far as surveillance because you can't see it, unfortunately. But genomically, from Pannin 1 to Pannin 3, there's increasing chromosomal abnormalities with increasing, you know, abnormalities in TP53, SMAD starts to mutate. So that's really the etiology that's going on here. But unfortunately, we can't see them. I don't know how we can find them, you know, going forward. But you know, it's important to point that out. Otherwise, a great talk.
Thank you, Dr. Frank.
Hey, Mohammed, I have a question. It used to be thought, at least CFTR mutations may kind of have an interplay with risk of alcoholic pancreatitis. In other words, those with CFTR mutations may be predisposed to alcohol, but I thought that was controversial. Did you come across, you know, if any of these mutations increases for alcoholic pancreatitis?
Yes, in fact, it's not the CFTR per se, it's the CASR mutation that increases the risk of pancreatitis in alcoholics. That was, you know, I think it was showed in one study that I quote here in 2015. And, you know, they show that CASR per se might not end up causing pancreatitis, but they're showing that it increases propensity or increases the likelihood of those with, you know, who drink alcohol to end up with chronic pancreatitis. Yeah.
Yeah, thanks for clarifying that. And you know, if I may make another comment, you know, in terms of familial pancreatic cancer screening, I think the big registries are Hopkins, Sloan, maybe Pittsburgh, but we collaborated with one of the registries, I believe Sloan, when I was at Moffitt Cancer Center, and at least the practice was if you start with an MRI, MRCP, because it's non-invasive, but if there's any abnormality, even if you know it's subtle, those patients will get an EUS because thought was they're complementary and you want to pick up even very subtle abnormalities in these patients who have like a 40-fold, at least in hereditary pancreatitis, 40-fold risk of pancreatic cancer. So they're often combined.
I see. So you end up getting both if you have any abnormalities. You start with an MRI and then maybe get an EUS.
If there's even a subtle abnormality, because often there's these tiny cysts which you might ignore in a patient without hereditary pancreatitis, but if in this population everything is perfect.
I see. Thank you, Dr. Vignesh.
Thanks again for a great talk.
Mohammed, I have a question.
Yes.
Sorry, can you hear me?
Yeah, I can hear you.
For the Spinc-1 mutation, is it autosomal dominant or autosomal recessive?
No, Spinc-1 is autosomal recessive because
okay.
Again, yeah.
Hold on. In one of the tables you put it as autosomal dominant, and then at the end you said it's autosomal recessive.
Did I? Maybe I mistaken.
But it's autosomal recessive, right?
Yeah. It's, I mean,
okay,
yeah, if you think about it, you don't need much Spinc-1 to inhibit trypsin, and only half of the amount is enough. So you need both hits to end up causing pancreatitis, or enough trypsinogen available to cause, or trypsin available to cause pancreatitis.
Okay.
All right. Hello? I think somebody is trying to ask a question, but.
Dr. Eidemann, there's something wrong with your mic.
Apologies, Dr. Ayman. Can you type that?
Mohammed, are you able to get that? It's
No, no.
really like,
Yeah, it's distorted. All right, hold on.
yeah.
Okay.
Mohammed,
Yeah.
that was from the Martian Gastroenterology Association.
I know, right? Transmission. Dr. Eidemann, I think your mic is very distorted for some reason. If you can dial in the meeting. All right. On this note, I think we're going to end the talk. Have a great day, everybody.